There were a number of interesting sessions here at ASCO, including one on new biomarkers and prognostic indications in leukemia and myelodysplastic syndrome. And I'm with Dr. Wendy Stock, who is a professor of medicine here at the University of Chicago. So let's start at that session. You were one of the discussants. What are some of the highlights that we need to know about biomarkers and prognostic markers?
Well, I think of the most clinically relevant abstract for this, of the three that I reviewed and discussed at this meeting, was the CLL abstract. And what the group did was, it was a large international collaboration led by the German CLL Consortium to develop prognostic and prognostic index, much like we have in some of the other hematological malignancies like lymphoma or myelodysplastic syndrome. And the reason for it, and I think a very useful one for clinicians, is that there's a plethora of prognostic markers, each of which have been validated in univariate analysis and in multiple different trials as a single prognostic marker. Now there's such a huge number of them that it's very difficult to know whether one can weight them, whether one is more important than another.
I think they looked at 26 or something like
yes,
that.
Yes, and they did.
Unbelievable.
That was unbelievable, but it was useful because what they did was, in their multivariate analysis, from 8 large randomized phase 3 trials of chemotherapy or chemoimmunotherapy in CLL, they were able to come up with just 5 markers, or 5 variables. I shouldn't say all of them. Not all of them are markers. Some are clinical features, which have long been a mainstay of prognostication in CLL. 5 of which turned out to be very, very important, and which they used to create a weighted index. And so if you get a certain number of these abnormalities, you have a higher score on a 1 to 10 scale. Those patients with higher scores have significantly worse prognoses. They were able to validate that in their small part of their training set, and then in a totally separate validation set from the Mayo Clinic, and it displays out very, very well. So I think it tells us a number of really important things that for me were very useful. One is that there's a weighting. Not all of the prognostic factors possibly need to be evaluated, and of the ones that were relevant, different ones have different impact. And so a lot of times we will see a patient with maybe one of these variables present that is an adverse prognosticator, but the others are not present. And this system now gives us a way to say, this is actually an important one, and if you have this one, you get this many points, and then that puts you in a very much higher risk group. So I think it helps us very much to understand which ones are important, which ones maybe we can order moving forward, and also identifies a group, a very, very high risk group, some of which we probably could have identified earlier, but definitely sorts out as a group that does not respond well to chemoimmunotherapy as we currently know it, and really lays the framework for prospective testing in novel therapies that are different from the standard, of which we now have also a plethora of exciting new agents to test in CLL. So I think this system will be very useful both for the practicing clinician to help prognosticate for patients, and for future clinical research to see whether this high-risk group should be shunted immediately to novel therapies, and whether or not those novel therapies then will improve their outcome in comparison to what has already been shown in this multivariable analysis.
So what else did you find in that session of interest?
There were, the other 2 biomarker abstracts were one extremely early and interesting but very preliminary observation that immunologic basis potentially for development of myelodysplastic syndromes, looking at the natural killer cell, the cure genotypes, and that I guess the bottom line is that we've often hypothesized and still continue to hypothesize and speculate that immune surveillance is very important in preventing the development of cancers in general, and also potentially in hematological malignancies, and that this association that was noted was that patients with fewer numbers of cure-activating genotypes were those who had higher risk myelodysplastic syndrome. compared to those with more activating cure genotypes, which are important for innate immunity, I should say, and that people who have potentially more active immune systems, surveillance going on, maybe have a lower risk of having high-risk MDS. But it's a very early association study, and that what I pointed out in that is that while it's very interesting and deserves to be followed up on, association does not equate with causality. So that was a second one. And the third one was actually a very interesting one in a number of ways, not as extraordinarily clinically relevant, but I think very clinically provocative, and something that's emerging as a very important theme in AML, which is that we understand now a lot about the molecular pathogenesis of this disease, and that it's a very complicated series of events that occur to result in the development, finally, of acute myeloid leukemia with a multi-step pathogenesis. And that really, a lot of what we do in the clinic is we study the bulk population of leukemia, when we really should be focusing in on the leukemia stem cell, the cell that initiates the leukemogenic process, and the fact that there are probably multiple subclones that are pre-leukemic at the time of even diagnosis and at the time of remission. And to understand that and to be able to study those cells better will give us a better handle on the disease development and who may be likely to be cured with current treatments versus those who still have a lot of bulk disease that's below the surface.
Right.
And their method of doing that was using this enzymatic reaction to test for this enzyme, which is a detoxifying enzyme called ALDH, aldehyde dehydrogenase, and combining that with flow cytometry to sort a very primitive myeloid population. And using that, they were able to identify subsets of AML that correlated with specific high-risk cytogenetic groups. But I think clinically of great importance is the fact that they show, again, that below the surface in people who are in remission with leukemia is a population of cells that are likely to give a rise again to the relapse. They may not be the exact same population of cells, but they're from a pre-leukemic clone. And so it may be possible in the future to use this kind of technique to test simply for the presence or absence of these pre-leukemic cells in people who we believe are otherwise in remission, to predict who is likely to relapse and who's not. And if we know that somebody's likely to relapse with our standard therapies, maybe then we can very quickly take them to a potentially curative allogeneic transplant. All of that remains to be tested prospectively. Yeah, it's interesting. And I think it again shows, though, that the study of the leukemia initiating cells is very, very important to our understanding of the disease progression and of the opportunity or the ability to assess treatment efficacy.
In the broader meeting at large, was there any particular session that you thought was clinically applicable for?
Well, I think there were some very interesting clinical abstracts presented at the leukemia session yesterday of some novel agents that actually, and I hate using the word promise because it seems a little false almost often, but there were some very interesting and hopeful abstracts of early stage trials for both AML. I thought was a very interesting and important abstract on a novel FLT3 inhibitor with a high response rate, and also another very interesting to me abstract for patients with myelofibrosis of a novel JAK2 inhibitor, which for the first time that I've seen actually seemed to improve not just symptomatic control of myeloproliferative disease, but also actually had an impact on the bone marrow environment by improving anemia.
It's Dr. Mesa and his group.
Yes, and I thought that was also a very interesting aspect. So those were two of the abstracts, and then of course the long-term follow-up on the CAR T cell, longer-term follow-up on the CAR T cell therapy for acute lymphoblastic leukemia, which I think is fascinating and extremely exciting for our patients who have these very difficult diseases. And so that was good to see the sort of continued support for very, very high response rates with this technology.
Well, I thank you very much for your time because
Sure.
this has been quite a complex meeting and it's been going on for a few days now. But for our coverage, please look around at ASH Clinical News for videos and also for reports that you can read from ASCO 2015. I'm Rick McGuire.